I think many Medicare Advantage plans are paying twice for the same evidence. And it's not because the evidence is missing, not because the provider failed to document it, not because the chart was never retrieved, but because once the evidence enters the data pipeline, only a fraction of its value gets extracted. The quality team uses part of it, the risk adjustment team uses another part of it. Sometimes months apart, sometimes through different vendors, sometimes after paying for retrieval twice. And I think that may be one of the largest hidden inefficiencies in healthcare quality operations today. Welcome back. My name is Peter Saah. Let's get into it. Most plans think they have a chart retrieval operation. I think what they really have is an evidence acquisition operation, because the chart itself isn't the asset. The evidence inside the chart is. And once the evidence enters the data pipeline, every program that can appropriately use it should benefit from it, whether it be in quality, risk adjustment, RADV, readiness, population health. They should all benefit from it. But the problem is that most health plans or organizations don't operate that way. Instead, each department acts as though it owns the chart. Quality retrieves evidence for quality. Risk adjustment retrieves evidence for coding. RADV retrieves evidence for audit defense. Each team extracts what it needs and moves on. The result is something I think the industry has largely overlooked. You see, we have become very good at retrieving evidence, collecting data. We have not become equally good at utilizing it. I call this the Evidence Utilization Gap. And I believe it is becoming one of the most important operational challenges in Medicare Advantage. Let me make this practical. Imagine a 68-year-old Medicare Advantage member that has type 2 diabetes, also has hypertension, has annual wellness visit with their primary care physician. One visit, one provider, one chart. Inside that chart is documentation for blood pressure, for lab results, medication management, chronic condition assessments. It may contain the physician notes, problem list updates. The HEDIS team looks at that chart and sees quality evidence. They may see blood pressure documentation for BPCA or BPD or CBP, HbA1c testing for GSD measure. They are focused on identifying measure closure opportunities. The risk adjustment team looks at the same chart and sees something different. Face-to-face documentation of chronic condition, right? Diagnosis specificity. HCC evidence that support RAF accuracy. It is the same chart, the same provider, the same encounter, but different lenses. The provider documented the encounter once, but many health plans extract value from it through multiple separate operations, sometimes through separate retrieval programs, sometimes through different separate vendors, separate abstraction workflows, sometimes months apart. The chart becomes the center of multiple operational activities, yet surprisingly little attention is paid to maximizing the value of the evidence once it arrives. That is a gap. It is not retrieval. It's not chart retrieval issue. It is evidence utilization. You see, I have become convinced of something. The most expensive chart in healthcare quality may be the chart you have already retrieved but never fully used. Think about the economics. The provider receives a request. The office staff spend time locating the record. The chart gets transmitted to you, right? Or to the retrieval vendor. The retrieval vendor ends up getting paid. The abstractor reviews the chart. Quality team benefits from it. Everyone moves on. Then, months after, another team begins searching for the same evidence that may already be sitting inside documentation the organization already possesses. And it's not because the evidence was missing, not because the provider failed to capture or document it, but because the health plan was not structured to capture the full value of what it already acquired. That is not a provider problem. It is not a documentation problem. It is not a retrieval problem. It is an evidence utilization problem. The urgency around this has increased dramatically. CMS HCC version 28 is now fully implemented, expanding HCC categories from 86 to 115 while removing over 2,000 diagnosis codes that previously generated risk scores. Conditions that contributed to RADV calculations under prior model may now carry zero weighting depending entirely on what clinical documentation it supports. So clinical specificity matters. Documentation quality matters more. Evidence quality matters more. At the same time, RADV oversight continues to expand because CMS is working to clear its audit backlog for payment years 2018 through 2024 and has significantly scaled its audit workforce and scope. So organizations or health plans are under increasing pressure to demonstrate that supporting conditions are supported by compliant documentation. So the value of every retrieved chart has increased. And it's not because the charts changed, but because the documentation inside those charts now has implications across multiple programs simultaneously. Quality, performance, risk adjustment, audit defense, and the same evidence, right, that supports all of them. And yet many health plans continue to treat that evidence as though it belongs to a single department. The cost of acquiring evidence continues to rise. The cost of provider aberration continues to rise. The cost of audit failures continues to rise, which means the value of maximizing evidence utilization also continues to rise. HEDIS and risk adjustment are not the same program. They do not have the same objectives. They do not use the same evidence standards, and they should not. But they also rely on remarkably similar infrastructure. Both require compliant source documentation. Both require chart retrieval. Both require traceability. Both require organizations to explain how the evidence was obtained and how the decisions were made. That is why I increasingly view retrieval and abstraction infrastructure as enterprise capabilities, not HEDIS capabilities, not risk adjustment capabilities, enterprise capabilities. Because the same operational discipline that allows a plan to defend the HEDIS closure can also support RADV readiness. The same chain of custody, the same source validation, the same documentation discipline. Different program, shared infrastructure, and yet many plans still fund and govern these capabilities as though they belong to separate departments. That separation creates duplication. It creates inefficiency. And ultimately, it creates missed value. There is another dimension to this that I think deserves attention, which is provider aberration. The provider documented the encounter once. The provider created one chart. Yet, the provider may receive multiple requests which is tied to the same documentation. One from quality program, one from a risk adjustment program, one from a vendor supporting a different initiative, one from a retrospective review project. The provider did not create 4 charts. The plan created 4 workflows, and those are not the same thing. Every additional request consumes provider time, office staff time, administrative efforts, and goodwill. And in an environment where providers are already overwhelmed by administrative burden, the question every health plan should be asking is simple. Are we maximizing the value of the documentation we already received before requesting for more? Yeah, that should be the question. Because every unnecessary retrieval request has a cost. It has a financial implications, not only financially, operationally, relationally, and strategically. See, whenever I evaluate an operational process, I apply what I call the CFO test. So imagine yourself standing in front of your CFO explaining the workflow. Would it make sense or would it sound ridiculous? Let's apply the test here. So we paid to retrieve a chart, okay? We paid to review the chart. Good. Then we paid to abstract the chart. We loaded the result into our system, into your system, and then 6 months later, another team spent money searching for the evidence that was already sitting inside the documentation the organization already possessed. I think most CFOs would ask the same question. And you can read my mind. Why? Why are we paying twice to extract the value from the same source? Why are multiple teams operating independently on the same evidence base? Why are we optimizing departmental workflow instead of organizational outcomes? And I think those are fair questions, because the issue is not whether the retrieval occurred. The issue here is whether the evidence was fully leveraged, fully utilized after retrieval occurred. Retrieval is an activity, but evidence utilization is an outcome. And organizations that confuse the two often end up investing heavily in evidence acquisition while under investing in evidence extraction. The strongest organizations are beginning to ask a different question. Not how do we retrieve more charts, but how do we get more value from the charts we already retrieved? See, that shift changes everything, because retrieval request becomes shared assets, not a departmental assets. CCD processing surfaces clinical content beyond HEDIS measure evidence, flagging chronic condition documentation relevant to your risk adjustment team's review. Abstraction evolves from measure-specific review into structured evidence identification. Let me be specific about what flagging means in this practice. When a chart is reviewed for HEDIS evidence or for STARS evidence, the abstractor simultaneously identifies clinical content that your risk adjustment coding team should review. Chronic condition documented with face-to-face physician assessment, chronic conditions that appear to meet V20H ACC criteria, conditions requiring annual recapture. That content is flagged and delivered to your coding team as a structured evidence note, not a coded HCC, not a RAV score. A flag that says This chart contains documentation of this condition assessed by this physician on this date. Your coding team should review it. Your existing risk adjustment vendor or coding team then makes the coding decision. One chart review, HEDIS or STARS evidence extracted, risk adjustment content flagged. Your coding team works from evidence that was already inside a chart that you already paid to retrieve. Most plans are asking whether they have enough evidence. The more important question is whether they are extracting enough value from the evidence they already have. One leads to more retrieval. The other question leads to better utilization. One treats charts as records. The other treats evidence as an enterprise asset. Many plans have already paid for evidence that they need. They simply have not extracted all the value from it. Like, you really need to squeeze the value from that chart. The chart, like I mentioned, isn't the asset. The evidence is your asset. The plans that perform best may not be the ones retrieving the most charts. They may be the ones utilizing the evidence they already have more effectively than everyone else. That is evidence utilization gap. Podero Health builds chart retrieval, CCD data processing, and medical records abstraction as one integrated program structured to extract quality evidence for HEDIS stars, flags clinical content for your risk adjustment team's review, and produce audit-ready documentation through single evidence operation. So if you want to understand where evidence value is being lost inside your current retrieval, as well as your abstraction workflow, that is the conversation a pilot starts. The link is in the show note. Thanks for listening or watching. I will see you in episode 12, and have a good one.